Hi, my name is Shahin Ghezelayagh and I'm one of the core medical trainees in Year 1 at Eastbourne District General, and this is a short presentation about my quality improvement project. So what is an occupational history? It's something we're all taught to do during medical school, where you ask somebody what they do for a living. We normally, during the acute clerking, ask people very basic questions, so especially if they're working age, what do they do for a job, and has their illness impacted their work? Why do we ask this? Because there's good evidence that your occupation can impact on your illness, and this is no more true than in the healthcare setting. We're exposed to things like bloodborne viruses that other populations simply aren't exposed to, so it's very relevant. This is a brief slide just taking you through some of the more common occupational diseases to be aware of. I think the most important one not to miss are occupational cancers, so this will include things you might be aware of like mesothelioma, but then also there are other cancers like breast and lung that have occupational elements within. In respiratory, there's a ton of conditions that can be affected by occupational risk factors, and that includes occupational asthma, and then of course mental health, which has come to the fore more and more lately. So for healthcare workers in particular, this mainly demonstrates that we're at increased risk of bloodborne viruses as well as other infectious diseases. So my first action was to audit whether we were taking occupational histories during our acute medical clerkings. So I audited documents in the AMU over a period of 2 weeks. I used strict exclusion criteria, trying to exclude anybody who was acutely confused, people that required a collateral history, younger patients, and also non-native English-speaking patients. The initial audit had demonstrated that only 6.5% of people had had an occupational history taken. We can see that in this slide in certain disease groups. Here we can see the limitations of the audit. To take this forward as a quality improvement project, I initially started with a PDSA plan to achieve an aim of 50% of working age patients having a basic occupational history taken at the time of post-take ward round. My driver diagram demonstrates the medical education as well as visual reminders would be the most efficient way of achieving those aims. This slide demonstrates the initial results of my quality improvement project. So after the first cycle of educational materials, our rate increased to 22%. Now following a second cycle of primarily visual reminders and posters, we managed to increase that number and improve it to 40%. So I waited 3 months before re-auditing to find that still 26% of people were having occupational histories taken despite no intervention since January. While this falls short of the 50% that I'd aimed for, that does represent a significant improvement from the 6.5% at the start of this quality improvement project.